EGM 컨퍼런스 시작하겠습니다. 한전 35세 남자 환자고, 집 컴플레인은 이제 응급실을 통해서 ICD 샥 이벤트가 여러 차례 들어가서 입원을 한 환자입니다. 현재 과거력을 보시면은 2021년도에 non-obstructive HCM을 진단받았고, 에이피칼 애뉴리즘을 같이 가지고 있었고, 유전적 검사상 TTM과 MIPM 뮤테이션을 함께 가지고 있던 환자였습니다. 환자는 이제 프라이머리 프리벤션으로 ICD 임플란테이션을 받았는데 그 이후로 이제 그 모노몰빅 VT가 다큐멘테이션 됐고 여러 차례 샥 이벤트도 있어서 약물 조절을 하고 저희 병원으로 전원이 돼서 이제 첫 번째로 이제 2023년도에 에이피칼 애뉴리즘에서 나오는 VT에 대해서 어블레이션을 진행하였던 환자입니다. 그 이후로도 아미오다론이랑 소탈로를 여러 가지 안티아리드미스를 썼음에도 불구하고 반복되는 샥 이벤트로 인해서 2024년도 1월에 이제 방사선 협진하에 SBRT까지 진행을 했었고 이전 과거력으로 이제 WPW 악셀 패스웨이에 대해서 포스테로 septal 악셀 패스웨이에 어블레이션 받은 히스토리도 한 차례 있었습니다. 일단은 가장 최근에 진행한 에코카디오그래피가 되겠고 HCM으로 그 미드 septum부터 굉장히 곱슬이 두꺼운 거를 확인할 수가 있고 이제 MRI 상에서도 그 이미 에이피칼의 그 스카 체인지가 다 오고 번아웃 스테이지로 확인이 되고 월모션과 함께 어, LV 이젝션 프랙션은 프레저베이션이 되어 있는 상태였습니다. 보시면은 에피칼 애뉴리즘 쪽에 스롬부스나 이런 것들은 확인되지 않고 머슬이 두껍고 약간의 페리카드 에피션인 걸 확인할 수가 있고 환자는 이니셜 진단 당시부터 카디악 MR을 보시면은 그 인버전 리커버리 페이지에 에이피컬 쪽에 굉장히 스카 체인지가 이미 상당히 와 있는 걸로 확인이 되고 있습니다. 그래서 23년도 11월에 이제 에이피칼 애뉴리즘 쪽에 유발되는 VT에 대해서 이제 RF 어블레이션을 진행을 했습니다. RF 어블레이션을 진행을 했고 제 왼쪽이 매핑한 사진이고 오른쪽이 어블레이션 닷을 포함한 사진입니다. 그리고 이후로도 환자는 계속해서 ICD에 샥이 들어가고 약물로도 조절이 잘 되지 않아서 다시 입원하에 SBRT까지 애뉴리즘 사이트에 이제 SBRT까지 진행을 했던 환자입니다. 다큐멘티드 된 그 VT 리듬에 대해서 몇 가지 보실 텐데 어, 네, 보시면은 이제 사이너스 리듬에서 PVC가 발생을 하고 PVC 이후에 모노몰픽한 VT가 확인이 되는 것을 볼 수 있고 ATP 터미네이션을 디바이스에서 시도했으나 터미네이션 되진 않고 이후로 이제 샥이 들어가면서 터미네이션 된 것을 볼 수가 있고 그다음 두 번째 심전도도 이제 VT 인덕션이 PVC에 의해서 됐고 몰플로지가 조금씩 조금씩 바뀌는 것을 확인할 수가 있습니다. 그리고 이것도 ATP 터미네이션이 잘 되지 않아서 최종적으로 악셀레레이션 되면서 ICD 샥으로 터미네이션 된 것을 볼 수가 있습니다. 마찬가지로 동일한 날에 비슷한 패턴으로 발생했던 VT가 되겠고 역시도 PVC에 의해서 트리거링이 된 것을 확인할 수가 있고 일단 그 7개월 이후에도 반복되는 ICD 샥 이벤트로 입원했을 때 중환자실에서 다큐멘트된 VT 이벤트가 되겠고 모노몰픽하긴 하지만 중간에 이제 엑시스는 유사하지만 몰폴로지가 조금씩 조금씩 바뀌는 것을 확인할 수가 있습니다. 여기는 아예 몰폴로지가 다 아예 다르게 변형하는 것을 확인할 수가 있고 이건 이제 이번에 그 최근에 ER에 방문했을 때 몰폴로지인데 이제 그 ER에 있는 모니터링상에서 단일 리드 2에서도 보면은 몰폴로지가 이렇게 순간적으로 이 팀에도 모양이 변하는 것을 확인할 수가 있습니다. 환자는 12리드 ECG 상에서는 사이너스 리듬의 레이트 46회, 이미 베타 블로커를 상당 용량 복용하고 있었기 때문에 레이트는 46회 정도로 확인이 됐습니다. 테스트 엑스레이상에서는 마일드 카디오메갈리 그리고 이전에는 그 ICD 리드가 관찰되고 있습니다. 이번에 EP 스터디를 시작을 했습니다. 카테터 포지셔닝은 다음과 같이 CS 카테터로 듀오데카를 넣고 그리고 데카플라 카테터를 그 LV에 위치시켜서 동시에 확인을 했습니다. 그리고 그리드 카테터를 이용해서 매핑을 진행했고 이니셜 리듬은 사이너스 리듬에 PVC가 프리퀀트하게 확인이 되었습니다. 그 세탈 펑처를 하고 그다음에 이제 세탈 펑처에서 그리드 카테터를 이용해서 LV 매핑을 시작을 했습니다. 카테터 포지셔닝은 다음과 같고 어, S1 매핑을 볼티지 매핑과 함께 시행을 했고 어, 왼쪽이 이제 이게 S1 매핑이고 위에 쪽이 이제 액티베이션 매핑 그리고 아래쪽이 볼티지 매핑에 해당되겠습니다. 그리고 주황색 선으로 보이시는 것은 매핑 후에 최종적으로 나타난 이제 아이소크로널 레이트 액티베이션 매핑의 슬로우 컨덕션 존을 표시한 것을 나타내고 있고요. 역시 에이피칼 쪽으로 이제 볼티지 매핑에서 보면은 이미 상당히 스카치 인지가 많이 와 있고 로우 볼티지 존에 쪽에 에이피칼 애뉴리즘 쪽으로 집중적으로 슬로우 컨덕션 존이 보여 있는 것을 확인할 수가 있습니다. 프로파게이션 매핑에서도 아이렘 매핑을 중점적으로 이제 프로파게이션에서 슬로우 컨덕션이 해당 부위에 확인되는 것을 확인할 수가 있습니다. 환자는 이제 매핑 과정 중에 이제 그 RV 페이싱에도 이제 VT가 인덕션이 됐고 보시면은 이제 뇌 디소시에이션과 함께 페이싱 비트보다 훨씬 더 빠른 VT가 인덕션이 되는 것을 확인할 수가 있습니다. 그리고 첫 번째 VT 몰폴로지는 네, 다음과 같습니다. 여기 12리드에서 확인된 VT가 되겠고 네, 그 다음에 VT가 이제 온고잉 하고 있어서 그때 VT1에 대한 액티베이션 매핑과 볼티지 매핑을 동시에 진행을 했습니다. 보시면 이 노란 닷은 이제 매핑 과정 중에 나타난 패셔네이티드 포텐셜을 보이는 에리아를 닷으로 표시한 거고 여기서도 마찬가지로 이제 VT가 온고잉 할 당시에 볼티지 매핑상에서도 에피칼 엔지즘 쪽에 로우 볼티지 존을 보이고 있고 여기서도 이제 아이렘 매핑을 했을 때 에피칼 애뉴리즘의 보더라인 쪽으로 슬로우 컨덕션 존을 보이고 있는 것을 확인할 수가 있습니다. 프로파게이션 매핑을 진행을 했을 때 V1에 대해서 혹시 에피칼 애뉴리즘 쪽에 보더 쪽에 보시면 슬로우 컨덕션 존을 확인할 수가 있습니다. 그리고 아까 노란색 닷으로 표시된 이제 곳은 이제 프랙셔네이티드 포텐셜이 이렇게 관찰되는 부분을 닷으로 AP가 엔지즘 쪽에 프랙셔네이티드 포텐셜이 관찰되는 쪽을 표시를 한 게 되겠습니다. 그리고 이게 과정들이 이제 S2 매핑을 같이 진행을 했고 S2 매핑도 역시 아이렘 매핑과 같이 아이렘 매핑 결과를 같이 보시면은 AP칼 애뉴리즘 쪽에 위쪽은 액티베이션 매핑이 되겠고 쪽에서도 아이렘 매핑을 보시면 슬로우 컨덕션 존이 대체적으로 에피칼 애뉴리즘과 그 보더를 따라서 슬로우 컨덕션이 관찰되는 것을 확인할 수가 있습니다. 그래서 프로파게이션 매핑을 보시면은 에피칼 애뉴리즘 쪽에 그 S1 매핑과 유사하지만 조금 더 이제 스페시픽한 보더존이 조금 더 구체적으로 로컬라이제이션이 됐고 아이렘 매핑에서 그것을 확인할 수가 있습니다. S2 매핑을 한 이후에도 이제 중간중간에 이제 인덕션을 확인을 했고, RV 페이싱 240에서 약간 모양이 다른 몰폴로지의 VT가 인덕션이 됐습니다. 보시면은 다른 리드는 비슷한데 이제 트랜지션 존이 약간 그 V2에서 3로 그 트랜지션 존이 변화를 했고, 리드 1도 약간 포지티브였는데 약간 네거티브로 네, 확인되고 있습니다. 이 VT도 계속 온고잉을 했기 때문에 VT2에 대해서 액티베이션 매핑과 볼티지 매핑을 같이 진행을 했습니다. 이 역시도 결과를 봤을 때 여기 녹색도 잠시 보여드리겠지만 프랙셔네이티드 포텐셜이 보이는 곳을 가스로 표시를 한 거고 액티베이션 매핑과 볼티지 매핑을 봤을 때 역시 에이피칼 애뉴리즘 쪽으로 스카체인지와 함께 아이런 매핑에서 슬로우 컨덕션 존이 있는 것을 확인할 수가 있습니다. 프로파게이션 맵을 보시면은 위치는 약간 다르긴 하지만 에이피칼 애뉴리즘 쪽으로 전반적으로 프랙셔네이티드 포텐셜이 존재하는 곳으로 슬로우 컨덕션이 같이 관찰되는 것을 확인할 수가 있습니다. 여기서 VT2에서 프랙셔네이티드 포텐셜이 보이는 부분을 다수로 표시를 한 거고 그래서 어블레이션 카테터를 이제 이 사람 피모랄 아테리 펑처도 같이 진행을 했고 트랜스 에올틱 어프로치랑 트랜스 셉탈 어프로치를 동시에 사용을 해서 에피칼 애니루전 쪽에 어블레이션 카테터를 위치시키고 아이런 매핑 했던 것을 기반으로 해서 어블레이션을 해당 부분에 진행을 했습니다. 슬로우 컨덕션 존을 따라서 어블레이션을 진행을 했고 최종 어블레이션 사이트는 다음과 같습니다. 어블레이션 다 진행을 하고 이제 다시 인버 인덕션을 시행을 했고 이제 트리플에서 다른 모양의 또 다른 모양의 몰폴로지의 VT가 인덕션이 됐고 보시면은 인페리드가 아까와는 다르게 포지티브 액시스를 보이는 것을 확인할 수가 있습니다. 그래서 세 번째 VT도 역시 온고잉 했기 때문에 여기서도 역시 아이런 매핑과 함께 매핑을 진행을 했습니다. 역시도 조금 아까와는 아까와 비슷하게 이제 AP가 애니즘 사이트에 슬로우 컨덕션 존을 조금 더 구체화된 부분을 잡았고 해당 부분에 대해서 이제 추가적으로 액티베이션을 했을 때 다음과 같았고 해당 부분에 대해서 추가적으로 어블레이션을 보강하고 이전에 했던 그 아이런 매핑 사이트 위주의 쪽 부분도 조금 더 보강해서 어블레이션을 더 진행을 했습니다. 해당 파이널 어블레이션 사이트는 다음과 같고 최종적으로 어블레이션 하고 추가적인 인덕션 스터디에서 더 이상의 타키카디아 인덕션은 없어서 시술을 종료했던 케이스였습니다. 시술 후에 사이너스 리듬
Let's go back to your cases. Very, very interesting cases. Complicated cases.
마지막에 위맵은 보여줘.
네.
레일 액티베이션이
네.
없어진 거. 그걸 꼭 확인해야 돼요.
Okay. So it's an apical form that clinically known to have a little bit worse outcome than the structural form. And this patient obviously has a very advanced PTC and apical variety. You can see MRI enhancement all the critical here all around. Notice that the scar is not homogeneous. It is inside of that aneurysm. Go ahead. Thomas.
잠깐만요. 여기 한 가지 더
야.
설명드리면 MRI 보시면은 지금 septum이 굉장히 두껍잖아요.
Right.
이쪽은 완전히 스카인데 there's myocard.
Right. But
So
we're gonna get to that in a minute.
set the posterior side as the epicardium.
But
Remaining
well,
also.
you notice that the very apex of the right ventricle. This is that high density enhancement gadolinium. Very apex of right ventricle. The right side picture. Right side picture. Yeah, right side. And right side.
This is
picture.
LV,
Right.
right side.
RV.
Yeah.
Apex. Okay. So anyway, so then go ahead. Let's look at your clinical DT trigger. The patient has a clearly trigger mechanism of tachycardia. And then apparently some of the tachycardia actually have a little bit more pleomorphic morphology. Now within the DT, they change the different morphology. It's called pleomorphic. Okay, it's not a multiple. The meaning of pleomorphic DT during the DT induction. Pleomorphic DT patients tended to be worse prognosis, higher incidence recurrences. Okay, so this is the important message. Is then you study, you look at the tachycardia, you start assessing approach this. Now, another thing that you notice that the patient PVC morphology, the two here, one trigger VT, the other one doesn't. First PVC looks like just cause a long sequence that preceding the preparing for the reentry, because it may cause a more conduction delay, impulse propagation, and sinus comes in second PVC, which a focal trigger comes in initiate. So that's the different meaning of that. And then that also evidence of what? It's a reentry VT, not a focal VT. Okay? Because when you have such long shot, what you do S1, S2 in the lab, same mean. Basically, this is a clinical scenario. Okay, go forward. And then basically antitactic pacing did not work. Keep on, it's fine. And then shock finally. Okay. So question that I keep on is what I think EKG wise is more PT mechanism, and that's now. If you see this patient, what do you think that this patient should be planning for? And we had this literally commented with Dr. Park before we came here, but you have MRI evidence involvement, perhaps LV apex, septum, maybe even RV apex. So keep going. And then this basically shows, okay, keep on. Okay. So now this chest X-ray shows that this patient, right there, you see apical apex tipping down to the diaphragm. You see that? It's a typical chest X-ray of apical aneurysm. We see same thing in Chagas disease. So when you see this type of chest X-ray, you start thinking these people may have apical aneurysm. Okay. There's only three diseases I should say that cause aneurysm. One is the LAD distal infarction, long aneurysm. Second is the Chagas. Third is the HCM apical variety. No other aneurysm that we know clinically causes it. That's the most common ones. That you're thinking etiology. Obviously, this patient already had a diagnosis of HCM, so that's what it is. Okay. So next. Oh, one more thing that go back there. You see that paginess in the apex of this here? You see this chest X-ray? If you epicardial puncture this patient, you're not going to that. They're going to be at this patient. So you should go more anterior or around. You try not to puncture that area. Whenever you see cardiac border, paginess like this, if you're planning to epicardial preparation, always clear, not to do this hate area. That's the important message.
Then how can I?
You can go to the anterior puncture, middle sternum, go down. Then you can usually separate out with the catheter. Those are localized small fibers.
Similar to that subtype.
So that was better. You go straight middle sternum anterior puncture. You got anterior posterior puncture.
I did the entry puncture yesterday,
Uh-huh.
but the needle was short.
Wow.
So I pushed the micron in the tibia inside. Guide one passed, but you're right. There was because of adhesion.
Yeah, this is.
I
That's correct.
cannot.
Yeah, so you must
small
puncture
guide
two
wire.
apically, try to get into. So you need to go puncture higher or around. Okay, it's an important message. So if you're planning to do procedure, epicardial procedure, chest X-ray, all those important information. Okay. All right.
Apical
Haziness, yes. Right there. You can see the pericardial wall right there. Okay. This is the meaningful, important information that we need to. Okay. Go forward. So PVC, I want you to look at this PVC. Look at the RV distal apex. How early this is? It's right here. Right? Your VT intracardiac signal wasn't earlier like this. All the VT. This will be proof for you to map the RV apex as well. Because it's septum default. Because you got pure R wave initial onset of that RV. So this PVC may coming from the subtle apical more toward the right side. So if you want to get rid of this PVC, probably you approach the both side. Okay, go forward. So I think catheter position all that well done. That's beautiful. Transubtle transaerial approach is the proper thing to do.
But the most difficult point was I cannot approach the very deep apex.
Right.
Yeah.
So
Always
those,
there's the barrier.
right.
Push the cap.
This, if you try the, instead of transit, subtle, probably transaerial would be better.
I did.
Yeah,
Both.
but then because of your aneurysm like this, so your bulging effect is very difficult to approach a lot of times. And then also MRI see some few trabeculation remain. Typically, annually becomes smooth, but this patient still has a trabeculation, so probably that's the reason that you can have trouble.
So without contact force, I cannot push the.
Right, exactly. I think, in a contact force, I don't use it, but we use for this structural heart disease BT, congenital heart disease, and so on, we should use the contact sensor. Okay, all right, go ahead. And if you look at this, ELAM map and the others, clearly evidence that your propagation map also show that the septum is involved, and then apex probably epicardially as well. You can see this wave of propagation disappears suddenly 5 years. There's a huge delay, what we call discontinuation of propagation map. When you see discontinuation propagation map, usually focus is a subepicardial or sub-midmyocardial, or they are basically within two structures, which will be septum. That's typically what we see. So in these cases, I don't know whether you guys do unipolar map analysis or not. Unipolar will be very helpful. Look at the EGM signature of the mid-myocardial potential, and then also epicardial prediction, epicardial potentials. So there's many literature published in the last few years looking at that use of unipolar signal for predicting subepicardial, mid-myocardial, so on. So that is really important.
So in the unipolar, it's the it might make the unipolar map, but all the red color, but in that area, small
voltage, yes. So that would suspect that you could map the right ventricle apex and then epicardial together. Then your map would be perfectly complete.
So yesterday, actually, I failed to have a puncture. Do you think is it valuable to do microcatheter map through the MCVT inside?
You can do that, but we use microcatheter catheter to the anterior cardiac gain, this kind of patients. Many times we use it because anterior cardiac gain will tell you that the septum is involved now because it runs through the septum.
But that area is very posterior.
Yeah, but it's still be useful. You can do MCV or either anterior both. You can do both. Actually, when the epicardial adhesion is very severe, we can go to epicardially. We always try to go to the cardiac vein, all of them. That's a very useful approach. So I would have done anterior vein and posterior vein in MCV as well. And the other issue that I see here is that your energy delivery is mostly posterior septal area when I saw your map. So go forward. And you can see the intracardiac signal key here. RD is early still. Okay, keep going. And the pure, keep going. There was the induction that you showed before. I just want to make keep going. The PC induction you did after the ablation. Keep going. I think at rest I don't need to comment. And then we talk about this line of induction, ELAM, all that stuff. This okay, there was keep on intracardiac EGM, but you guys just the PT forward, keep on. So it's the same thing. You gotta basically wait from break and the pause between the last and then the last activation. So whenever you see this, you really need to start thinking
This is S2
map. Yeah.
I
Keep going.
compare the
Same thing.
S1 map and S2 map side by side, almost
Same, exactly. Yeah. Go on. So right here, not go back. Okay. What does this EKG induction mean to you besides the BT induction? A lot of people say, oh, BT induced. No, that's not true. You got to look at your pace to R pure respiration, induced BT. Take a look at it. This is evidence that this is epicardial BT because you're pacing RV because the endocardial focus, you could be pretty close to morphology of what QRS with. This is a much wider, increased calculation time is very long. This is a hallmark epicardial BT. Okay? So not just look at the induction. You want to look at the induction EGM as well. This will be very important message. So every bit of your data going to be important for this kind of patient for you to plan what is my next step. So I think look at the QRS duration matters, EGM duration matters. Look at the EGM here, much wider QRS duration, local activation time wider. So all this is add up. But furthermore, look at this signal here. This is the RV, small notching right there. You see right there, right? Those signal suggestion of what? Far field early activation, right? The local is right behind it. So then you know your RD index is not right at it. But if you look at the RD, that signal, what is it, 6? Is that RD 6 or 3? A 6. There's a positivity there. No, 좀 더 앞으로. Yes, right there. That's early, but also positive. And then between two, biphasic. So you know wavefront breaking between the two. So you already then marked your subtle area involved in this patient. So I think this further evidence that you should map the right ventricle as well. So I think I commented I would recommend the RD apical path map making, and then also epicardial map. I would comment. Okay. Otherwise, I think that.
Why did we use several types of BTN before it goes? Is it reasonable to map PDCs?
I think
Which
that's
type of
correct.
BTs?
And in a structural heart disease BT, people only think about the reentry, but you need to know if there's a focal trigger, you need to get rid of both. You just don't get rid of reentry mechanism tachycardia. As long as your focal trigger continue to prevalent, recurrence is much higher because of that keep firing and putting another unidirectional block cause of BT, unless you get rid of all the substrate, which is quite impossible in this kind of patients, especially subepicardial or mid-myocardial, you're trying to do. Plus our current technology, we cannot really predict well where the location of a mid-myocardial scar, where the propagation conduction curve and the elam happening in myocardium. Roderick Tong put out a bunch of artificial imaginary circuit in the paper, but does not really, we don't even know that's true. Okay, bottom line.
But yesterday during ablation, after the blocking the late activation, the U-shaped the curve, I saw the dissociative potential.
Right.
But it is far field.
Far field,
So
yes.
probably
Epicardial, more mid-myocardial, whatever, yeah. Epicardial. Even you probably map the epi angle together with the patient
that
because
must be.
your
Yes.
time phase is different. Because you got the angle map first, then you got the epicardial map. Obviously, activation is not same during that time. That's how we cannot create a truly 3D, transmural activation. Your apical focus are firing. So what could be a epicardial breakthrough endocardium? It turns around and firing the focal trigger. So that might be what's wrong. That does not mean, that's whatever, you see as a purpose. So we need much to learn about this still. I don't think we are there. As you know, no matter how we do, BT recurrence is still up to 50%. Also, this type of BT we operate, no matter how we do it. So I think it is very much we interested to research in this area, but unfortunately, as we talked about earlier, does not change the patient's survival outcome, no matter what you do in this type of patient. We just improve their quality of life, prevent ICD shocks, and then also anxiety of having office. Certainly helpful. And the emergence speed is going to be lesser. Those are bad purpose. I think it's still very, very important because these patients have a post-traumatic shock syndrome from multiple shock. They're very emotionally stressed. But
Emotionally, he improved a lot.
good for you.
Because initially,
Yeah.
he came due to the BT storm.
Right.
But afterward, most of BT terminated by
Yeah,
ATP,
patient, yeah.
but the intermittent
Yeah.
shock.
Those are benefiting, but I think it's very, very important. Yeah, you give them a quality of life, give them optimism to survive again. Those I think, but I don't think we can change anything.
I stopped the near the road.
He's 35 years old.
Because I could not.
Not possible.
At least.
With a blockade and things like that, we find
Yeah.
to watch how she does. And older patient probably doesn't benefit too much, but a younger the age benefits. So my argument is that I talk about this too. Korean people in general, when I go visit to help them out with such this kind of case, they tend to indicate the BT origin too late. That shouldn't be because we know HCM, desmoid plaque cardiomyopathy, many other congenital diseases, when they start with non-sustained VT, you start planning VT ablation because you don't want to delay. Then you start having 3D imaging, much as possible, all you want to see. And then they have an increased number of non-sustained VT and monitoring or ICD, you better bring to the lab study, VT study list. See what type of VT in this. If appropriate, ablate it. That is a much better approach than last minute VT storm patient is sick, acidotic, decompensated, you change the case, patient not going to be a lot worse. Because this is going to progress. What's the point of waiting? Doesn't benefit anything.
Please let us know your opinion regarding the Vanish 2 presented the last AHA.
Yeah.
And it was the RCT comparing the amiodarone versus ablation after first.
Yeah, amiodarone is the worst trouble you can cause because you hide a lot of, for example, mask the critical tachycardia, but also alters the critical tachycardia circuit because amiodarone never meant to terminate tachycardia. Last 40 kph reading music. Mostly you see slow the conduction of velocity of the VT. Therefore, your functional reentry mechanism, scar function delay become delayed. That's why the VT cycle is longer. Because critical is still sitting the same when you map. Therefore, you may lose that critical, propagation like H2 or ELAM map. Therefore, you may miss a critical circuit of tachycardia. So I think that's what the reason that the amiodarone is worse than the VT ablation itself.
After listening your opinion, the young EP faculties looks
Change their mind?
very happy.
Okay, good.
You want to ablate this?
Yeah, I think because of
They're always ready to
yeah,
ablate.
we don't gain anything giving amiodarone to people. Plus, not to mention side effect, but they are functionally not really good for them. And amiodarone, they say, oh, it does not affect the ear. It does. If you really measure carefully, after amiodarone, your normal function ejection goes down. Of course, because it has a sodium channel effect. It's gotta be. There's no other way around that.
It was first time for me to do map the island using the HD grid yesterday.
A lot of fun.
Yeah, it's something new. What?
Yeah. Plus, does not cause too many PDC, so you can have a lot of fun with that. And unless Johnson and Johnson come out with that new catheter, which has a much better sort of a high resolution mapping. But again, the high resolution does not mean is that you're going to see through whole thing. No, high resolution density map mean less penetration through the myocardial layer because the electrocyte is too small. Electrocytes need to be reasonably big. The spacing of recording has to be reasonably big enough to look at the mid-myocardial epicardial potentials.
So
And that's a downside.
I will ask the Apple to develop the ILM subtraction map.
Right. That would
The
be
subtract
right.
near field.
Right. Yeah. But it's not going to be that easy because of they don't have data of how much that grid catheter component they're recording is near field and far field. Maybe frequency, according to Bill Till's paper, frequency analysis may help you a little bit, which one is the far field and near field. But just looking at the eyeball, no, there's no way you can do that. Yeah, that's why, I look at the EGM many times. I always wonder if this is something that we can really resolve by the manual looking eye examination EGM. No, I think you have to have AI technology or something.
Wow, it is first time to have your comments. The new technology and software better than your eye.
Yeah. I think I'm looking more. I look at these cases. I think we really need more help because simply we don't have a true anatomical definition of what we are ablating. Same as APs. If it was much thinner, we can't even do that with. You're gonna be PT. It's very impossible. That's why I think I have a many questions about pulse field. You don't know how much pulse will penetrate, how much is reversible, how much is irreversible. I'm sure in scar tissue, pulse field is going to be less effective. That's for sure. Even though you ablate RF first and deliver pulse with additional shock to increase the depth. Both of technologies, scar does not respond normally to these energies. So we have no idea what it is.
Let me ask the RF effects in the scar area because the scar tissue has a low impedance
Correct.
and the RF energy spread to the scar area easily. But for the remaining myocardium, it's less effective.
Right.
Right?
Alright.
So in that case, what should we do? Increase the power or
I think
increase
you
duration?
have to ablate longer duration.
Longer duration?
Yeah, not the power, because if you increase the power, you're gonna have a more resistant pattern.
Mhm.
So your energy delivery, longer duration gonna be basically abated much, so. But I think you're hindering your effort to try to create a deeper lesion, more homogeneous lesion. So I favor for longer ablation rather than high power.
Recently, there are many reports regarding the lipomatous.
Right,
infiltration.
metalloplasm,
Yeah.
yes,
It
definitely.
is the,
That changes the whole goal.
important role in the VT mechanism.
Yeah.
Unfortunately, scar and lipomatous tissue has
Complexity.
different,
Mhm.
opposite,
Behavior,
compared to the
right,
RF
yes.
physics.
Because
So,
RF cannot penetrate because of
Right.
another regions of barrier. So, there's a more postmortem specimen data coming out here and there. Patient had RF ablation and subsequently they passed away. They able to get the heart specimen looking at the histopathologic correlation. That clearly shows whenever there's fat tissue available, around the scar, you're done then, you're done gain. This is very much, I think gonna be same as the pulse field, same as RF, no matter what kind of energy you use. Now, one energy that you mentioned that potentially is with the super high power cryo may penetrate the whole thing. Okay? But then that,
Adagio.
yeah,
Adagio
yeah,
system.
that problem is that, pseudo formation is because you kill the whole layer and then the separation accumulation bloody. So that is a danger.
I'm not sure that in those patients who's very.
Right,
I
no, you're
don't
not
think
safe to
that-
use those,
I
yeah.
don't think that. Adagio
Septum,
can-
I think is useful, and then I think free wall is useful, and then potentially, and annulus particularly, I think is very useful. But I do not know what's going to be result of that in terms of valvular structure function. That is a danger, we don't know that yet. So I think we still need to bottom line, we need to map, need to be very, very careful. We can really just push this issue without knowing reasonable
Best
sacrifice.
approach is reasonable RF energy, power, and the longer
Longer
duration.
duration, yes. And watch for spin pump. Because the impedance can tell you that too. So I think those guidelines will be safer this time. And then try to image as much as you can. No matter how good you guys, intracardiac echo might be, still old fashioned LV gram can be very useful.
Yeah, I think.
Yes, I know, but for people who are younger, they should really seriously think. Especially when don't have a 3D, LV gram still works pretty good. I use the Myanmar LV all the physical rehabilitation, everybody. Wonderful, image you can get that. Okay, anybody has any questions, please?